Assalamu alaikum. My name is Marryum Zahid and I am a clinical dietitian. My topic is effect of artificial intelligence on nutritional status of children post cardiac surgery, a randomized controlled trial. Malnutrition. Malnutrition is a big problem in CHD patients and it ranges from 15 to 50%. And even if we look at the normal children of Pakistan, according to the National Nutrition Survey, this trend of wasting is increasing. Like in 2011, it was 15.1, and the latest that took place in 2018, it is 17.7. A study was carried out in AFIC and IHT in the children in 2019, which showed that the in-hospital mortality is 21%. And in that 21%, only 3.4% of the children had normal weight, and 47% of the children were underweight, and 49% of the children were severely underweight. But it is said that algorithm-led nutrition therapy, attention to the energy and protein goals, and a devoted nutrition support can actually prevent this malnutrition post-cardiac surgery or decrease it either, and bring better post-operative outcomes. So the objective of my study was to assess the effect of artificial intelligence on nutritional status of children post-cardiac surgery in comparison to the usual care group. That was the group in which pamphlet was given post-cardiac surgery on the discharge, and to assess the usefulness of diet-related mobile application in comparison to the usual care group. So this was my methodology: the enrollment, informed consent, screening in terms of weight, height, and the blood test, and the training of the mobile application with the allocation was done in the first week. Then the intervention carried for the next 8 weeks based on the diet-related mobile application and the pamphlets. And the patient used to come for echo or routine checkup at 5th week and 8th week. At that time, we used to check their weight, their intake, and everything. The trial was registered on clinicaltrial.gov, and the duration of the study was 6 months, from February 21 to July 21, and per patient each patient we gave 8 weeks. The allocation was done through permuted block, and the recruitment was done through chronically numbered, opaque, sealed envelope. Inclusion criteria: the children of 2 to 12 years were included in the study. Surgeries with first and second class of RAC score were included. Then patients with smartphone and internet facilities were included. The patients with caregiver who could read English were included in the study, and the patients discharged from the study from the hospital were selected. Patients with multiple congenital abnormalities were excluded from the study, and that patient who, if come back and re-hospitalized, was excluded from the study. So this is our mobile application. The name of the mobile application, we kept Eat Baby, because it was for the kids. This was first page is a sign-up page. Then we can write the name and we can enter the gender. And after adding this information, we used to get whether the child is underweight, overweight, normal weight. And then the application used to tell us that how much calories that child requires, how many proteins, fats, and vitamins and minerals were required. And then if we used to select a diet plan, there were numbers of 3 to 4 options. One was vegan option, one was like high protein option, and the one was normal option. Once we used to go in the diet plan, the child could change the options. Even he could add porridge instead of a banana, or bread instead of, he could change according to the preferences. So the results of our study was, total surgeries that took place from February to May were 142, and in the end, after randomization, we included 40 usual care children and 40 AI group children. And in the end, after death, loss to follow-up, we have 32 total children in usual care group and 29 in the AI group. So the weight changes, there was not a very drastic weight changes in that short span of time, but there were like 2 to 3 kg of weight gain in most of the children, even in the AI group and also in the usual care group with the pamphlets. So this is the graph we can see. I I think it's not. But we can see the blue one is the weight at the discharge. First one is the AI group with the 29 patients. The other one, the low one, is the usual K group. Blue one is the weight at discharge. Red one is the weight at 4th week when the patient used to come for the first follow-up, and then the last one at 8th week. Similarly, in the calories consumption, the required was almost 1000 kilocalories. Even the usual care group took, like, at 4th week 999 kilocalories, and then at 8th week the average intake was 972 kilocalories. And then in the AI group, in the 4th week there was 997 kilocalories, and at the end of 8th week there was 1000 kilocalories average of 29 patients. So this is even the chart. The top chart is of the AI group, and the second one is the usual care group. The protein consumption, the required were 44 grams per child average, and the usual care group at 4th week took 34 grams at 4th week, and even at 34 grams at 8th week. They were consistent. But AI group took 36 grams at 4th week and 39 grams at 8th week. So this is the graph. The upper one is the AI group, and the low one is the usual care group. So the problems, we actually asked what the problems people face, the AI group, the people with using the mobile application. The problems that were found during the handling of the application, 69% of the patients found once a week at 4th week. And then once a week were 17% and 14% who had never any problem while using the mobile application. But after they told us their problem, we tried to solve a bit, and at 8th week, this 69% reduced to 46%. Then the dietary goal feature. Once you enter your weight, you get the calories, and then they define your goals that you want to take calories like 1200 kilocalories, 60% you want to take carbs. So this is a dietary goal feature of the application. So how many people found it that it was useful? At 4th week, only 52% considered it as a useful tool, useful feature. And that when we told that how can they further use it and how can they use it like for the eating and how they can change it, so 79% of the people increased and found the usability of that feature. And similarly, the language, in the first 4 weeks, 83% had difficult to understand as it was in English. We are trying to convert the language in Urdu. It's a very difficult process, but we are trying for it. 83% found it difficult, and then we went for the translations and everything at the 4th week. So, and at the end of 8th week, 70% found it understandable, that application. So the diet planning tool preference at the end of intervention, at 4th week, 7% considered it that pamphlets are better, 35% considered pamphlets and application both should be given, and at 59% said that mobile application is a good option. And then at the end of intervention, at 8th week, 35% considered that both options should be given, pamphlets and mobile application, and at the end, they said 79% said that mobile application should be given. So the conclusion of my study is that despite of many limitations were of internet, of the signal problems, of money problem. Money was like, even most of the patients don't have mobile packages to install the mobile application. So we actually shared that through a share application. So there is a chance of this application in future. There were average income status and nutritional education level of patient's caregiver, and it was between low to average. But still, they were although very, very slow, but they were ready to adopt this technology. There was a slight increase in weight and nutritional intake of both groups, and actually we recommended at the end that if we take this application or this study for a longer period of time, we can actually see better weight changes and better input of the patient's caregiver. Thank you. Any questions?